So the topic of today's lecture is anti-arrhythmics, and anti-arrhythmic drugs are used for arrhythmia that may be caused by the abnormalities in the conduction or in the muscle conduction system, heart conduction system. And the difference in the heart muscle is that it has intrinsic automaticity and can contract itself without influence of the central nervous system. And there are special conductive tissues that are in heart, including sinoatrial node and atrioventricular node, and the Purkinje system, and this will lead to the automatic contraction. And usually the automatic contraction is led by the sinoatrial node because it is the fastest one, and this node can spontaneously depolarized and lead to the depolarization and contraction of the muscle, and that triggers the contraction of the atriums and then ventriculars. So heart will contract rhythmically, starting from the atriums and then ventriculars. So the blood first goes to the atrium, and then from the atriums to the ventricular, and then from the ventricular to the aorta. So the pulmonary aorta or the primary aorta, depending on the circle of the circulation and the right or left side of the heart. And the conducting system makes it to contract synchronically, like every part of the heart contracts at the particular time, so the blood flow will be continuous, so they will not contract simultaneously. The different parts of the heart will not contract simultaneously, but they will contract in one by one. So there are several groups of the drugs that are used for treat the abnormality of the heart contraction or the arrhythmias, and these include the 4 classes. So class 1 is a sodium channel blockers and is divided to 3 subclasses: A, including disopyramide, procainamide, and quinidine, and then the B, that is lidocaine and mexiletine, and C is propafenone and flecainide. So these are the sodium channel blockers, are most common drugs used for the arrhythmia. The second the second class is beta blockers, and mostly metoprolol is used, but also esmolol and atenolol can be used as anti-arrhythmic drugs. Metoprolol is available for extended release form and also as a intravenous solution. So beta blockers are also used for the many other diseases, including the congestive heart failure we studied today, and the arterial hypertension, and many other diseases. So then class 3 is the potassium channel blockers, and potassium channel blockers include the amiodarone and dofetilide, dronedarone, and ibutilide, and sotalol. So different chemical structures, but still the same blocking, potassium channel blocking activity. And class 3 drugs are less commonly used and also more dangerous than other classes. And then the last is the class 4 is calcium channel blockers, including the verapamil and diltiazem. And nifedipine is also a calcium channel blocker, but not used as antiarrhythmics, but used for other indications. So the calcium channel blockers are the least commonly used drugs because of the many side effects, including the fatigue and the some dyspnea. So these are less common. And then there are also other antiarrhythmic drugs, including the adenosine, digoxin, that is the cardiac glycoside, mostly used for the congestive heart failure treatment, but also has some anti-arrhythmic properties. And then magnesium sulfate, mostly used for the hyperarrhythmias, because decreasing the calcium, replacing calcium and decreasing the heart rate. So, and also the decreasing the blood pressure. So this is the classification of the drugs, and there are maybe several abnormalities that lead to the arrhythmias, and one of them is the block of the conduction. So when the nerve pulse travels, and then if there is a block in some part, then that can lead to the reverse of the conduction. So the conduction will travel the different way, and also sometimes it leads to the re-entry. So re-entry is a special type of the conduction abnormality when the conduction will travel the upside down. So it will travel from opposite direction. So normally conduction goes from the atrius to the ventriculus, so from the upper side of the heart to the down side. But when there is some block, for example here, then the conduction can travel the opposite direction. So this is because the conduction blocked in one direction, and that leads to the retrograde conduction travel, and that leads to the irregular heartbeats, and that are called extrasystoles, and that can be very dangerous. So the mechanism of action of drugs corresponds to the different to the influence or to the different phases of the depolarization. The sodium channel blockers will slow, so they will slow or shorten the different phases, except for the class 3 potassium channel blockers. So for the sodium channel blockers, they slow the phase 0 depolarization. For the so it's for the drugs 1A sodium channel blockers, and 1B will shorten phase 3, and the 1C will slow phase 0. So same as 1A. And then the beta blockers class 2 will inhibit the phase 4, and then the class 3 potassium channel blockers will prolong the phase 3. So the class 3 prolongs phase 3, that is easy to remember, and it is a right opposite to the 1B because 1B will shorten phase 3. So different opposite influence but the same antiarrhythmic action. And then the class 4 or calcium channel blockers will inhibit all phases, so all action potential in all nodes. So this is also quite different from other drugs. And depending on the type of the arrhythmia, different drugs are preferred. So there are 6 main types of the arrhythmia, and arrhythmias are classified according to the anatomical structure. And anatomically, arrhythmias can be atrial and ventricular. So, and also supraventricular. So that are actually in between. So, and the most common are atrial arrhythmias that include atrial flutter and atrial fibrillation. Atrial flutter means that there may be excessive fast contractions of the atrium, and the drugs of choice for the atrial arrhythmias are class 2 and class 4. So usually metoprolol is used for the beta blockers class 2, and the verapamil or diltiazem is used for the class 4. And then atrial fibrillation is a very potential hazardous disease because can lead to the death. So atrial fibrillation is more dangerous than atrial flutter because atrial flutter can be patient can survive without treatment. Atrial fibrillation usually requires prompt treatment. And then the class 3 amiodarone is also indicated, as well as anticoagulant therapy with aspirin. So then the second group is the supraventricular tachycardis. So supraventricular tachycardis can be mostly 2 types: atrioventricular nodal re-entry, that is this re-entry when the conduction re-enters where the block, so, and that is retrograde conduction travel. And the re-entry atrioventricular nodal re-entry is treated with a metoprolol or verapamil, same as the atrial, so class 2 and class 4. And the second type of the supraventricular is acute supraventricular tachycardia, mostly treated with the adenosine. So adenosine is actually decreases the heart rate. Then the most dangerous arrhythmias are ventricular, and ventricular tachycardis are treated mostly with the class 1 and 3, so mostly with lidocaine. Lidocaine is injected intravenously and mostly effective for the acute ventricular tachycardia. And amiodarone, that is class 3 potassium channel blocker, is also mostly effective. And then the most dangerous type of the arrhythmia is ventricular fibrillation. So atrial fibrillation is also dangerous, but ventricular fibrillation is even more dangerous because it is not responding to electrical defibrillation. So as known as, you probably know, the electrical defibrillator that can be found in some hospitals, and the emergency units can be used to treat all types of the arrhythmias and to reload the heart because when stimulated by the defibrillator, all parts of the heart are contracted fast, then all of them will relax, and then eventually the heart will start from the beginning, and that helps to synchronize the uh, contraction of different parts of the heart, but for the ventricular fibrillation it is not effective and also dangerous. That is why it should not be used. But the epinephrine can be injected intravenously, and amiodarone is also indicated for the treatment. So this is the drug choice of the drugs uh, during the different types of the arrhythmia. So I think that is all for the Saturday lecture. So and what are your questions? No questions? So then thank you for your attention and see you next week.
Goodbye.
So, goodbye, teacher.